but, oh, that's better.
Have we lost you, Rabbi?
Well, he is going 90 miles an hour down the interstate. God knows where. You're probably going to lose him and get him and lose him and get him.
Yeah. Well, then we'll look forward to him.
It's good to have we've got some new. We have feedback on my. I'm here. Can you see me?
Oh.
We lost you for a minute there.
I hope you're not driving.
No, I'm not driving. My wife's driving. Okay. Can you hear me now?
Yes.
Yes.
Okay, good. All right, I think I hit a bad patch of. So I don't think there's any particular order for our speakers today. I just want to let you guys, our guests, introduce themselves. I know that we have, specifically, we've got Bev Coulter and Frank Miller going to talk about some of the health perspectives from the Jewish perspective. And I don't have the names in front of me, but who else has signed up today for our presenters?
Bill Hicks.
Bill, you're going to, okay, and then we'll hear from Bill Hicks. So Bev, I don't think you've been on these calls before, so why don't you tell us a little bit about yourself, and then we'll do the introductions, and then we'll just get started.
You said Bev?
Yeah, we'll start. Bev, just introduce yourself, and then
Okay.
we'll get started.
I'm Beverly Coulter. I'm an adult nurse practitioner. I've been doing this for 40 plus years, and I'm not 80 yet, but I've learned a lot. I'm an endocrinology nurse practitioner now. I worked for Memorial for 20 years in internal medicine. So I take care of a lot of endocrinopathies, including type 1 and 2 diabetes. There's also now a type 1.5 diabetes, autoimmune disorders such as Hashimoto's thyroiditis, get a little bit of hypertension, a lot of polycystic kidney disease, and I just had, well, I better shut up and let other people introduce themselves. I'm starting to get into my spiel, so thank you, Rabbi.
So we're really glad you're here, Bev, because you bring a lot of expertise, and
Thank you.
I think it'll be very interesting to hear what you have to say. I know, Frank, I think you were going to share something, so just let us know a little bit about you, Frank.
I'm a nephrologist, adult kidney diseases. I've been practicing for 40 years now. I'm not 80 though. And so, Helen, I saw that. Anyway, I'm pleased to be here and talk a little bit about some of the Jewish related diseases, but I've been intrigued by what I've read about a lot of the diseases that are found in blacks and the discrepancies between the rates of disease in blacks versus Caucasians.
Okay, and Bill, can you give us a little bit of background? I know you've been at every one of these meetings, and a little bit of background perhaps as pertains to the topic today.
Before we hear from Bill, may I just say one thing? Because Bill is going to start off, I think, a lot of this conversation. But I want people to know that it would be a pleasure to hear from you after this dialogue, your perspectives. Send me an email with a couple of sentences about what you think, what you want to see happen, what is your focus, and I'll put it together in an article for the American Diversity Report and quote you. So keep that in mind, that all of you have assignments as we hear from our panelists. So Bill, I'll turn it over to you.
We're on fall break, so I'm not doing any homework.
We'll see.
Okay.
You will come by.
Thanks, Rabbi and Deborah, and all of you who are on this call. I'm Bill Hicks, and I'm formerly the Executive Director of the Chattanooga-Hamilton County Medical Society here, and I'm also been in the past the Executive Director of Erlanger's Southside and Dodson Avenue Community Health Centers. My background is in public health, and I've been in the field for oh, maybe, and it surprises me, as long as Dr. Frank Miller's been in medicine. I didn't think I was that old, but Frank and I go way back because he was on the executive committee of the Medical Society that hired me as the executive director back in 1997. And again, as I mentioned, my background is in public health. I hold a master's degree in that field. And I've been very interested, obviously, in disease experiences, what we in the business call the epidemiology of diseases. And with your permission, Rabbi, I'd like to give a kind of a platform from which Frank and Bev Coulter. By the way, Bev, I think you treated me on many occasions when I started over at Endocrinology Associates in practice when I was diagnosed with type 2 diabetes. You were the first person other than Dr. Huffman who actually treated me for that. So thank you. It's good to see you again.
My
Indeed.
pleasure. Nice to see you.
Well, you know,
I would love to hear your platform. So just go ahead and take the floor.
I'm going to be kind of brief because thanks to Deborah, there's an article out in the American Diversity Report. It's entitled Health Disparities and the Culture of Lack. And I put that out and she published it today. But just as a background piece, health disparities describe differences in outcomes from disease experiences. And there's a lot of information out there about that. The statistics tell us that the incidence, that is the number of new cases, and the prevalence, that is the number of cases of any given diagnosis in the population, are fairly the same, regardless of what subgroups of the population you look at. They vary only slightly. For instance, in the top 10 diagnoses among African Americans, you find at number 7, homicide. For the top 10 diagnoses for white Americans, you find suicide at number 9. My issue is that if, in fact, the disease experiences are not all that different in terms of the morbidity and mortality rates, morbidity being, the rates at which sickness occurs, and mortality, of course, being the death rates, then what is the issue that drives these disparities? From my perspective, the issue that drives the disparities is basically economic. And when you think about other manifestations of disparities, most of them, if not all of them, derive from an economic disparity, because in this system, access to healthcare is driven by economy. I remember in the past when most people got their health insurance through their jobs, or if they were poor or old, they got their health insurance coverage through Medicaid or Medicare. And now, Medicare, since I'm an older person and I do, get Medicare, some of the issues associated with that, I know Dr. Miller's going to address, but, there's a donut hole in Medicare, which says that you have to spend your way out in order to be able to get the system to cover your services. For me, that describes what I think is a fundamental value deficiency in our culture, and that is the culture of lack. It means that in some way and somehow somebody's got to do without so that some other person or persons can have more than what they may need in order to be able to get the necessities associated with maintaining positive well-being. So for me, it's not, I can look at the various top 10 diagnoses, and we did a lot of this work when I worked in Washington and went up on the Hill to make cases for funding for federal programs. But also even here in this community, there's not that much variation. So the issue with respect to the disparities in health outcomes has to do, in my opinion, with access. And access in this culture is driven by the economy. If you don't have a job, you can't get coverage unless you're old and you're on Medicaid or Medicare. And if under those circumstances, the policymakers shift the variables associated with the benefits packages that are covered under those programs, then you get adverse health outcomes. Now, of course, many of the socio-demographic issues like age and sex and ethnicity, et cetera, even geography will impact the outcome as far as health disparities are concerned. But even all of those, when taken together, in my view, they find their derivation from economic disparities. Now, my own personal perspective is that until we find the will to be able to address those economic disparities towards being able to make sure that everybody has access to something that is going to give them a basis, and in fact, a comprehensive basis of coverage for the disease experiences that we are having nowadays. We got problems. And you can even see it now with the COVID-19 pandemic. The over impact, if you will, of COVID-19 is mostly on people of color and the elderly. You know, the most vulnerable and least able economically groups in our culture that, you know, are being the ones who account for most of the deaths associated with COVID-19. So that's the platform. You know, I would encourage you to read the article that's in the American Diversity Report, and let's, you know, see where we go from there. Thanks, Rabbi.
Thank you, Bill.
Well, I'm not sure how to follow up on that. I totally agree with you, Bill. Don't really have any answers to suggest. I looked at a couple of clinical articles that talked about the human genome, and the human genome has only been discovered and unwashed a decade ago, regarding the role of race in genetics that has advanced at a rapid speed. 23andMe, Ancestry.com, etc., and so forth. You can learn a lot about yourself and others just based on those reports. The cost of that testing is getting lower. Right now it can range from $100 to $2,000 per test, contingent with the nature and the complexity of the test. There are many newborn testing screens, and in many cases health insurance will cover the cost of genetic testing. Looking at my practice, just briefly, I saw a new patient the other day that listed her ethnicity. I shared this with Frank the other day, listed her ethnicity as Ashkenazi. And my nurse came to me and said, what does this mean? And I said, oh, she's Jewish. So I walked in and I said, welcome to Chattanooga. She was from New York. And have you affiliated yet? You know, we Jews are always wanting more members in our individual temples. And she said no, and she said, I'm so glad that you knew what Ashkenazi meant. But with this patient, I immediately became suspect of a few diseases, including breast cancer. And yes, it's not an endocrinopathy, but it is something that Ashkenazi Jewish women do experience frequently genetically. She also had an autoimmune Hashimoto's thyroiditis, PCOS, insulin resistance. Tay-Sachs is something that's quite rare, but it's also genetically carried by the Ashkenazi Jewish population. Frank will go into this, but there are three subsets of Jewish people. The Ashkenazi Jews from Central and Eastern Europe, the Sephardic Jews from Southern Europe and Northern Africa, and the Mizrahi Jewish people from the Middle East and Arab countries. So when I saw her, I knew specifically tests I would be running, my workup, just based on some of the traits that Ashkenazi Jews are at high risk for. When I see African Americans with type 2 diabetes, I immediately suspect kidney disease and worry about the control of their blood sugar related to the long-term effects on the heart, the eyes, the kidneys, the neurons in the lower legs, neuropathy. The other thing that we look for in the African American population is beta thalassemia and sickle cell anemia in the young complaining of chronic pain. I know it doesn't have a lot to do with what Bill just said, but I just thought from a clinician standpoint, I would share with you what I see commonly and what we look for in our practice.
Thank you. Before we go to Frank, I just wanted to point out something that's interesting, is that as we are asked a general question, I've already, we have two very different responses to the same question of what are the the health issues in the particular community. And I think that it's just something to note that the glaring issue for everyone is access to healthcare. And it's felt particularly hard amongst communities where there is economic stress, and also disproportionate exposure to the COVID disease as well. So that's an incredibly important issue, and it's certainly the way Bill understood this question. And then Bev heard it from more of a clinical standpoint, where it's what are the diseases that are perhaps more unique. So I think as we go through the rest of this conversation, I really do think that we should spend some time with each issue, because they are prevalent amongst all of our communities, and important to address as we move forward. So also, Bev, you brought up sickle cell, and also you mentioned Tay-Sachs. And that is something that's very common between the Jewish and the African American communities, is that we have these recessive gene disorders that pop up, and that we should be pre-tested for. I know a lot of Jewish, and I think Frank's going to talk about this, so I'm not going to take take the air out of his sails here. But and I know sickle cell is also something that gets tested early, I believe, in the African American community. So go ahead, Frank, and see if you can tie them together for us.
Okay, thank you. Thank you. First, I want to just sort of mention something about the Jewish diseases. And as Bev has indicated, there's sort of three groups. The Ashkenazic Jews are the ones that came from Eastern Europe, and these are the ones that most of the Jews in the United States are Ashkenazic. Then there's Sephardic Jews, who were related to the expulsion from Spain, which occurred in 1492. Started the day that Columbus left for America, interestingly. Anyway, these Jews had to leave Spain, and they went to Northern Africa, they went to Greece, they went to Turkey, they went to Italy, they went to Syria, and many of them actually speak a language called Ladino, which is sounds very Spanish. And then there's the Mizrahi Jews are the ones who have always been in the Middle East for many years. Associated with these groups, because of long-term intermarriages, there's been genetic diseases. Particularly, we've mentioned Tay-Sachs, which has been in the Ashkenazic and the Sephardic community. There's Gaucher's disease, cystic fibrosis, there's spinal muscular dystrophy, and in particular, the one that we hear most about are the BRCA1 and 2 genes that are associated with an increased incidence of breast and ovarian cancer. And this is something that we see very commonly. And Jewish women apparently have an incidence of about 1 in 50 to 1 in 100 of carrying this genetic disease. Sephardim, the Jews from Spain, beta thalassemia, cystic fibrosis also occur in this group. There's also a disease called G6PD deficiency, which is associated with a hemolytic anemia. This is also in the Sephardic community. But really what has interested me in my reading that I've done in preparation for this is the increased incidence of common diseases in the Black community. And I found it when I read exactly how the numbers are so much higher, it really made me think of exactly why. And let me give you some for instances. Diabetes mellitus, 60% more common in Blacks, and they have a higher incidence of limb amputations, chronic kidney disease needing dialysis, and loss of vision. Asthma, very much higher incidence in children with asthma, have a 3 times the death rate of white children. Why is this? Sarcoidosis, which is an unusual rare disease, is 16 times more common in blacks. And interestingly, to Chattanooga, Reggie White died of sarcoidosis complications. Lung cancer, 50% higher rate in black men than in white men. Strokes are 4 times as common in middle-aged blacks. 4 times the number of stroke deaths. Hypertension develops at a much earlier time in blacks. And secondarily, the hypertension leads to heart disease, chronic kidney disease, and strokes. Even cancer, there's a 40% higher death rate, not incidence, but death rate in black males, and a 20% incidence higher in females. So when you look at this, why does this occur? And I think certainly part of it could be genetics, but in looking at it, I really think environment and socioeconomic status really play a major role. If you look at the vaccination rates, blacks have half the vaccination rates of whites. However, look at why these diseases are more common, particularly like cancer and lung disease. Blacks are much more likely to live near a toxic waste dump. Blacks are also more likely to live in areas that are polluted. And as we all know, we've seen the numbers that blacks are more likely to die of COVID-19. So we have a problem with access to health care. And at least in my opinion, I think everybody in the United States is entitled to health care. I think we need some type of universal health care to get us to where we need to be so that all people have access. I mean, I will say I was always proud of our practice because we saw every patient, whether they had insurance or not. And I felt very good about that because we knew that since we were the only kidney group in town, if they didn't see us, bad things could happen. So we saw everybody. But everybody needs to be able to pay for their own health care, and I think some type of national health care is justified. I think if you took all the money that went into our healthcare system from insurance paid by businesses, from co-pays, from all the things that we have to pay for, I would think that we could get some type of national health care with the same amount of money that we're putting in for right now. Now that's just my opinion, and other people I'm certain would think differently. But I think everybody's entitled to health care, and I've talked too long, so I'll throw it back to Deborah.
Okay. Well, I would like to say something as someone who has been an urban planner, and appreciate your bringing up the issue of the environment and what that does to our health.
Deborah, can I pause for just a second? I want to go ahead and click mute all, and then we'll have the speaker who's speaking unmute, so that because there's a lot of background going on, and I want to make sure that we focus just on the speaker. So I'm going to go ahead, click mute all, and then Deborah, you should be able to unmute yourself.
Sure.
Hang on just a moment. Okay, Deborah.
All right, as I was saying, as an urban planner, it is obvious to me that we have over decades used neighborhoods that have been more poverty-stricken, more African-American in many cases, to dump refuse of various kinds and make the neighborhood basically toxic. We are coming to the point where we're all going to be paying the price for this in terms of our water, our food supply, our air, and we don't really pay as much attention to it unless we're actually in those neighborhoods. But none of us are exempt, and it is taking a terrible toll of our health. And I so appreciate your bringing it up, Frank. And I wonder what other people think about this too.
Well, this is Bill again. Just for a little background, here in Chattanooga, there was a designated Environmental Protection Agency Superfund site on the south side of Chattanooga. The Chattanooga Creek is still polluted, and it runs right through the neighborhood, which is predominantly African American. The physical plant is, and when I say that, I mean the houses and the businesses in that area are still, well, not vibrant. They're not healthy, and many of the people that we saw at the Southside Center were bringing things to us that were a product of the environment in which they lived and worked, because and that there was I guess it was called Velsicol chemical plant and a glass making plant down there on the south side that during my 6 years as executive director of the health centers, those sites were never addressed. They were never dealt with in terms of abating the environmental hazards that existed in those places. And so, you know, and on top of the other things that the people who use the health centers, who were predominantly African American, because the health centers were placed in what were deemed by the federal government to be target areas, and those target areas were geographically described as being poverty stricken. On top of the other things that they came to us with, like high blood pressure and diabetes, et cetera, there were some cases of persons who were exposed to environmental hazards and the diagnoses that developed as a product of that. So even right here in our own community, we've had, you know, that kind of experience that Deborah just described.
Bill, if I could ask a question about that, what do you think, if you had to guess, where does that start? How does that sort of environmental, obviously it wasn't always that way. And I was just doing some reading not too long ago about just education inequality, and some of the situations you described seem to go hand in hand with some of the discrepancies in education also. So where does it start, and which one is the catalyst for the other?
Well, let me say this. The Southside Health Center was located in a school building that was on the south side, as far as I don't think it's still there now, located in that particular area. But we couldn't use 2/3 of the building because it contained asbestos. Now imagine a health center located in a facility that was deemed uninhabitable because of asbestos. Where something like that starts is in the public policy arena, in my opinion. When regulations and rules are a bit lax, and businesses and others can use less than optimal approaches to the development of environments, buildings and houses and otherwise, is going to expose the population to greater risk. And then on the other side of that, the Velsicol plant and the glass making plant that are still sites on the south side that have not been abated, the people who still remain in the community are continually exposed to things like that. Now, again, the EPA had designated the South Side as a Superfund site, but nothing ever happened in order to be able to take advantage of that. So I think, you know, to piggyback, if you will, on Frank's point, we're talking about a public policy change, which not only creates access, but empowers and enables abatement of environmental hazards. I think we need to do some things in terms of health promotion and education for better health behaviors. In the middle of the 90s, 80% of what went wrong with us in terms of the presence on the top 10 diagnoses were derived from behavior. We smoked too much. We didn't get enough exercise. We ate poorly. You know, those kinds of things can be addressed if people are educated. I think, Rabbi, you mentioned education, to be able to do something like that. In the middle of the 1980s, when I worked for the National Association of Community Health Centers as their director of research, I did a survey of the health centers. It had 5 components. The sixth component was, what are you doing in the area of disease prevention and health promotion? But those services were not funded by the federal grant that those health centers received. And yet they were providing those kinds of services. Now, I never got a chance to do a follow-up to understand the impact of those kinds of services, where they were being offered in terms of, and what I was attempting to do was to measure, was there any impact on the top 10 diagnoses encountered in those health centers who had those kinds of services versus those who did not. But I think, you know, what you and Frank are saying is education, you know, but education, not just in terms of the risk factors associated with disease, but how do you prevent, how do you educate to be able to avoid those risk factors? That in my view is where you start with something like this.
If I could just
And
add,
don't get me started about TennCare.
if I could add a comment.
I'm going to,
Yeah.
is that
may I
Deborah
comment,
Dubel?
or
Please,
I
yeah.
was just going to say that it's a whole ecosystem. You know, when I think about Flint, where I was in Michigan, and the water issues, I think about living in Michigan before with auto industry waste. Manufacturers were here on the south side a long time ago. They were dumping stuff into the grounds, and we didn't have requirements. We have now relaxed environmental requirements that say it's okay to dump things. And so what happens is, then when the manufacturing plants went away, we didn't clean up the grounds. Developers were allowed to build without cleaning up the grounds and requiring people to clean up. And this goes on and on and on. And people are allowed to live in these places without these things being enforced. So, you know, recently they did a soil test at my home. I was thrilled to test for lead, but that's not everywhere. And they're starting to catch up in certain places. I'm hoping to God the school across the street from me, they tested for certain things in the soil. But those are things that we can enforce, but it does take public policy, it takes government, it takes requirements on all these factors. It's a whole ecosystem to me. Education certainly is a piece. And the water Flint situation continues.
One thing I'd like to add to this in terms of the environment is food. Okay, we're looking at two groups, both the African American community and the Jewish community, that is very vulnerable to diabetes and related issues. And what we eat, how we eat, is very key to controlling it. We live in a country where fast food is sort of the norm, and trying to get away from it is very difficult if you're used to it. Now, COVID-19 may have forced us to do that at some point, but I'm wondering, how are we going to move forward with what we've learned during COVID-19 about cooking? Can people actually cook anymore? And if they do, what happens when you have a neighborhood, and we have several here in Chattanooga, that are food deserts, that there is not a grocery store, there is a gas station maybe where you can buy stuff. What is the impact of our food design on our health, and can we do anything about it?
Well, let me.
Christina has her hand raised.
Okay.
Hi, everybody. My name is Christina Harley. I'm in California, and I'm actually a playwright. But I wanted to just share my thoughts about this particular question. My family lives in Cleveland, Tennessee, and I have an uncle who has diabetes very severely. He can no longer walk. And he has lost the use of both of his feet. They're very swollen, and he can't walk anymore. And what I know is he was diagnosed with diabetes. He had plenty of time to change his diet, and he didn't. And I know the reasons why. He didn't want to change himself. It was too difficult. He didn't really believe that the consequences were going to be as severe as they were. And he just plain loved what he ate, you know, what our family fried chicken, sugar, and absolutely didn't want to change. But I also know that in our family, church is very important. And if there's a way to introduce any sort of change, I think churches are a great place to begin. If there were some sort of awareness class that a minister would embrace, I think that would be a great place to begin within the African American community. It's always going back to the churches. I think especially for this type of topic, which is food and making changes in that area. Those would be my thoughts.
Thank you, Christine. I think places of faith certainly have a role to play in education and also in influencing policy. So thank you for sharing that. I see that Barbie Potts also has her hand up, and before I pass to Barbie, you just triggered for me another thought about this too, and that is on a personal note, we lost my mom to type 2 diabetes, and it wasn't because of a food desert, it wasn't because of lack of access, and it's about another thing, and that was probably tied to mental health, depression, anxiety disorders that can then lead to eating disorders that then lead to type 2 diabetes. So that's certainly another area of interest, perhaps, that we're not going to be able to cover today, and that would also be the mental health aspect of these issues. So Barbie Potts, I saw you have your hand up.
So I just wanted to let y'all know, before I was a nurse, I was a dietitian. And so I have spent most of my career in education. And I'm just hearing over and over again that we really need to educate people. And I love that idea of it starting in our churches and our synagogues. And I just want to let y'all know that I would be happy to teach any classes on nutrition that anybody would like to hear. But I believe education is definitely where it's at for helping prevent these diseases and teaching people that it's not expensive to eat healthy. I think that's one of the biggest things I would always hear is that we don't have access to healthy food, but you can teach someone to eat healthy and not spend a lot of money.
Barbie, is that going to be before or after we serve the kugel and the brisket?
Or the pizza.
The pizza.
I think Ms. Harley said something I'd like to also respond to because it dovetails for me into some of the things that we've been discussing. She mentioned the influence and impact of the church as a medium through which a message about how to eat better and take better care of yourself from a dietary perspective might come. Yeah, I grew up in the church as well. And for us, a lot of the times in the African American community in the church, that was the place where you got your most significant meal of the week. The issue was what was cooked and what was served. Now, I used to be my grandmother's runner. She was the cook, and she managed that kitchen like a good captain manages a ship. But the things that were coming out of the kitchen, and we didn't have any sense that it might be, in the long run, harmful, were things that were like beans with fat pork, neck bones, collard greens made with pig knuckles, things that were either high in fat or high in sugar. My grandmother made the best sweet potato pie that this world has ever seen. It was so good, it got me a job because I took it with me to the Syracuse in my first professional capacity after graduate school, and they ate that pie and they hired me. But how do you then either train the cooks or stop laughing? It's true though. But how do you train the cooks to cook differently? How do you make sure they have access to the kinds of vegetables and other healthy food items that they can use? And then as a product of preparing those, educate those who come to them for that meal. Then on top of that, recall that, the income disparity between the Black community and the general population is really great. I think Rabbi mentioned some of those at the outset of this. So, and then you have a food desert where the food is simply not there. It's not available. Never mind accessible, it's just not available. And I think while that may be a real influential way to manage or to at least address the issue of how people eat, it's also got to be supported by access to the right foodstuffs, the cooks in the kitchen having an idea of how to cook and what to cook, and serving the kinds of meals that then people can take home and model in their daily existence outside the synagogue or the church.
It would be interesting, and I kind of joked about this, and Leslie, I see, I'll call you in just a moment. I mentioned to Barbie kind of jokingly about the ethnic foods that we would serve at Temple and then talk about nutrition. But when people come to our temple, they're expecting a certain traditional on fat, you name it, right? They're not healthy foods that make up our ethnic food. And, so it would be shocking if somebody came to temple and all of a sudden we served a very healthy, nutritious meal. It just would say, well, I could have done that at home. Why did I do it at the temple? So it'd be an interesting thing for us to shift. I'm not sure if we can make that shift for food that we serve at the temple. I'd like to try. Leslie.
Thank you very much. I just have several reactions. One is to you, Rabbi, and the other is to Christina. I'm what's called a psychoeducator. It's a subset of clinical psychology, and I work in Hungary. Hungary is a unique situation because it's post-communist, and I came here very early in '91, right after the Berlin Wall fell. And I found enormous problems that may be relevant to issues that you're talking about, because psychoeducation didn't work. What worked was family psychoeducation. That is, certain types of illnesses require change in lifestyle. And I'm just an old man. You put food in front of me and I'll eat it. I'm not a dog, but I'll eat it. And what is needed is for families to get together, go shopping together, cook together. And I don't want to be chauvinist in this, but maybe the wife, if she's the cook, can take a lead in what is being served. So this is just one area, diabetes, and many other related problems. The coronary problems that we're talking about, I think are related to this. I hope that's a little bit helpful. Families need to get involved, not just the chef or the cook, whatever. It's a family issue.
And I think also curbing the reflex to just go for the easy, fast calories too. I think I'm definitely guilty of that sometimes. It's like, do I want to spend 30 minutes cooking and 30 minutes cleaning, or do I want to just order a pizza? Yeah. And sometimes it's cheaper too, honestly, to order the pizza than even do the shopping. So that's another problem. We've talked a little bit about that with food deserts and availability of nutritious food. I see Vanessa Jackson has her hand up.
Good afternoon, everyone. Just to sort of piggyback off what already has been stated with regard to, I guess, healthy eating, I would like to also see more community gardens here in our city. I think that we have a number of them that are successful. We have a number of, I guess, churches that provide free vegetables, maybe like once a month or so forth. But we really could benefit from having more community gardens within neighborhoods, within maybe sections of communities. I don't know if you all have noticed it. I'm sure you have. I mean, since the onset of COVID, of course, it seems as though most of what we're doing is going to the grocery stores and going to pharmacies and just taking care of our basic sort of needs. But I have been noticing just the rising cost of, you know, even basic foods within the grocery stores. And you know, for me, you know, it's been most apparent because I'm in a situation where not only am I shopping for myself, but most times to keep my parents safe because they're, you know, in their 70s. I try to do a lot of their shopping as well. So what I would like to see is more community gardens and opportunities for people to be able to get healthy foods at a affordable price, and then to learn how to choose those options and to prepare them. Another thing that, you know, we of course we have in our city, Chattanooga, Tennessee, is the mobile market, which is sort of a strategy to help to offset some of what we're seeing in some of our food deserts when that mobile market comes to different areas within our city, and mainly coming to, you know, areas maybe where there are low income senior citizens living in concentrated housing or so forth. And I know recently I saw a documentary on our public broadcasting station about the mobile markets and about them coming to Patton Towers, which is a senior apartment facility in downtown Chattanooga. And while, you know, it has greatly provided a service and a way for those individuals who live there to be able to get fresh foods and vegetables, you know, it came with a cost. And some of the residents mentioned the fact that, you know, I'm glad that they're here and I don't have to go as far, but, you know, it is a bit more expensive. And sometimes some of the alternatives that we bring to communities where, you know, by we're providing food, it may not be, you know, at a cost that is affordable. And so I think that plays a lot to do with our success in remedying these issues in minority communities, particularly the Black community. Sometimes the strategies that we use, you know, even though they may work, they too have they have their limitations, and they may need to be tweaked or offset in such a way so that we can really get to the crux of the issue and help to be able to really have effective outreach and trying to correct these disparities on health.
Thank you so much, Vanessa. I think we've really introduced a lot of potential plans of action that have risen up here. And I'd like to throw something back at, you know, at Deborah Levine, sorry, she's a Levine, where we've talked before about once we get out of this COVID mess, what are things that we could do together as far as programmatic and community building things. And I think one great thing would be to start some of these healthy food classes, or they could be cultural exchanges using healthy recipes and doing some cooking together. It'd be a lot of fun, and it would be helpful for building on what we're talking about right now.
Hey, hi, this is Bill again on the
Yes.
Public policy front. And, you know, Deborah and I share a bit of background as far as land use planners is concerned, or land use planning is concerned. Deborah, what do you think about the idea of public policy that encourages the kinds of food growth areas being built actually into the environment that Ms. Jackson mentioned? I know when I worked in urban planning, none of that was ever considered. You know, encouraging or finding incentives to be able to get people to build into development projects, spaces where the people who lived in those areas could take advantage of it and start to grow their own food.
Well, we do have some community gardens already going in very good places. They are not run by individuals or individual families necessarily, but by organizations. And I think it would be very helpful to promote those organizations, give them visibility, make sure that they're well funded, give them the opportunity to speak about what they do. I'm thinking of one in particular, which is opposite a huge was it the old Harriet Tubman apartments that is now going to be turned into an industrial park. We need to pay attention to the urban planning that we have going on and what that means for the surrounding community more and more. And I really invite people, again, to write to me about what they see, about what they want to see, so that we can start to give that visibility, because otherwise it can get easily swallowed up as sort of a very nice but not necessary kind of project. And I hate to see that happen. We need more of it, and not just for this generation, but I'm thinking of the coming generation of kids, right? Who I really worry about in terms of what they're getting in schools, what they're eating. I think of Halloween coming up and the amount of sugar that is going to go into individual bodies, right? And I wish there was an alternative. If everyone would just give out like pennies or something. Just saying. But because we have ingrained in our people, in our population, that celebrations mean sugar. And somehow we need to change that. I don't know if we can, but those of us who have to watch our sugar know that it is doable.
You're not encouraging children to swallow pennies, are you, Deborah?
No, I'd rather they would not.
Okay.
But they might make a nice collection, and that's what we give out for the neighborhood for Thanksgiving when we can. And one of the things that you know, it wasn't always this way. For example, what was it, bobbing for apples? Remember that, doing that as kids? Anybody do that anymore? But it's a great party thing. Maybe it's time to pull that back up again. Apples are better than candy corn.
So we've covered so many different areas. Because again, somebody mentioned zoning. I know in addition to community gardens, I think that would be a wonderful step towards community cooperation, towards bringing healthy foods, making it more accessible, but also developing a taste for it. Because breaking away from the fatty, sugary foods, you have to develop a taste for it to want the community garden. So what other things can we do? And like I said, somebody mentioned zoning before. What are the kind of zoning policies that we can do that could actually make food or areas less desert-like when it comes to food, and to promote better food? Does anybody have any ideas there? Leslie has his hand up. Sorry.
Yeah. I'm seeing a very hopeful group. It's very nice to connect with Americans. Let me say that much. We were talking about the issue of policy. I can't overemphasize that. The policies that I have seen here in Hungary are beyond belief. I hope eventually I'll be able to write about them. But what happens with policies, sort of like what Pastor Hicks pointed to, they just are sort of invented by people and then they don't change. If there is some way to give feedback to Deborah, and then she can funnel that in some sort of manner that is heard and acted on from the people, bottom up again, that would be an enormous step. Another area that I just want to point out is that because of the failures of policy here in Eastern Europe, enormous tragedy occurred, long period, enormous funds were wasted. And because of this, there was research done that there is a sort of way of introducing what's called anthropology of policy, that is humbly being able to build in, are we going in the right direction or are we making mistakes now? Ongoingly examining policy rather than as a big ego boost, holding on to it firmly. This is my idea. I'm a big shot. I'm the policymaker. And let's forget your complaints. So that's my input, again, from Hungary.
So I know at the beginning we talked a lot about the specific diseases in different communities. I think one policy area that we should look at is testing. I know that's been a big buzzword in the midst of the COVID crisis. But also when it comes to other things, there are ways to test so you can at least anticipate medical needs and offer early treatment. And I know that we've also talked about stresses, and I think that's a big one. When it comes to dietary, depression, anxiety, economics, stress is a number one thing that's going to keep triggering all of these things. And if we can find a way to create some sort of balance where there's less stress, something like Frank mentioned, where we actually have accessible, affordable medicine for everybody, that would certainly be a start. Job opportunity, that kind of thing as well. So I'm hoping that when we write our homework for Deborah, that we'll all have some good ideas for how to move forward.
Yes, please. And I'd like to add one thing that you mentioned about the genetics. Both our communities suffer a great deal from breast cancer for a variety of reasons, of whether it is DNA or it is the pollution. And we do have, I believe, a mobile breast cancer unit that goes through and does testing. Maybe we can promote that and make sure that women do get tested, because testing and getting it early will save lives immeasurably. And I say this as somebody who has not only lost her mother to breast cancer, but, and wait for it, guys, my brother. This is not just a woman's disease. Pay attention and let us all make sure that we're thinking of our bodies and taking care of them.
You know, the actor
sure
Richard Roundtree also had breast cancer. He played the original Shaft. So male breast cancer is indeed a real challenge and a real issue.
Yeah, without a doubt. And I think it's another thing what we, protecting pre-existing conditions is going to be essential to that, because I know when people get tested to see if they have even a genetic tendency towards these cancers, that then it can be labeled as a pre-existing condition. And in previous days, those diseases wouldn't get covered if you had the test early. So, you know, that's something that's in the air these days, is talking about the pre-existing condition that might be a deterrent to testing. And we have to remove that barrier, keep that barrier away. All right, let's see.
Down in
Deborah Duba is giving points. So Richard's got one, Vanessa's got one. I'll look at research. Richard says vote. Okay. Yes, I agree with that. Well, thank you, everybody. I think I appreciate Bev, Frank, Bill, and Deborah. Always your participation and input on this is incredible. I learn so much every time we do one of these sessions. I'm glad to just be along for the ride, figuratively and literally today.
Hey, let me give a shout out right quick to Dr. Les. He and I went to school together. I'm not going to tell you about how long ago that was. Good to see you, Doc.
All right. Everybody, Deborah, do you have, I forget what the date is for the next one. It's the second Sunday in November?
That's correct.
Is that
the second Sunday, 4 p.m. as it is
4 p.m.
today. And I'll be putting it out, as will you, I'm sure, in the MISPA.
Yeah, we'll promote it in the MISPA newsletter as well.
Right, and people are invited to come and invite others to join us. This is a conversation that I think can boost more than just our Chattanooga conversation and community. Thank you all.
All right,
And
thank you, everybody.
don't forget your
Vote.
homework.
Vote.
Vote and homework.
Vote only once. Don't vote twice, just once. But yeah, but vote. Make sure it counts.
All right. And send
All right.
your sentences to Deborah, DEBORAH, at diversityreport.com. Okay, I'm putting it in the chat.
All right.
Okay. Bless you. Thanks.
Thank you, guys. Everybody have a great rest of your Sunday, and we'll talk to you soon.
Thank you. Blessings, y'all.
Thank
Thanks
you.
so much.